Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Hey everyone! This presentation begins by defining the kinematics of trauma and the stages of a traumatic event. Then, kinetic energy is discussed, followed by the mechanics of blunt and penetrating trauma. Let's get started. Definition. Kinematics is a branch of mechanics that deals with the motion of objects without reference to the forces that cause the motion. The kinematics of trauma is looking at a trauma scene and attempting to determine what injuries might have resulted. So essentially, you're looking at the mechanism of injury. An understanding of kinematics allows pre-hospital providers to suspect certain injury patterns with certain mechanisms of injury. So understanding kinematics of trauma, you can start to suspect injuries even before you get on scene if you have an idea what occurred. The traumatic event. There's 3 stages of a traumatic event. The first stage is the pre-event. These are all events that preceded the traumatic event. So this takes into account the patient's medical history, whether the patient ingested any substances like alcohol or illicit substances like drugs. Also takes into account the baseline mental status of the patient and emotional and social history of the patient. The second stage of a traumatic event is the actual event. So this begins at the time one object impacts another. So for example, a car crash, you have 3 different impacts. You have the impact of 2 objects, say a car hitting another car. And then you have the impact of the patient into the actual vehicle. So say the patient hits the steering wheel or is ejected from the vehicle. And then you have the impact of vital organs inside the patient's own body. So organs hitting each other, organs hitting tissue, being sheared or torn away. All traumatic events involve energy exchange between moving objects and body tissue or a moving human body and a stationary object. So, for example, you have, say, a bullet hits the tissue of the body, right? That's penetrating injury. Or you have a human body is ejected from a car and it hits the ground. That would be human body hitting a stationary object like the ground. The third stage of a traumatic event is the post-event, and this is typically where emergency medical response comes in. Kinematics can be used to determine what injuries may be present. Scene survey is key to determine what mechanisms of injury may have occurred. So we want to ask questions like, what does the scene look like? Who hit what at what speed? What objects did the patient strike? And were patients restrained in a vehicle if it is a vehicular accident? Kinetic energy. Newton's first law of motion is a body at rest will remain at rest, and a body in motion will stay in motion. 3 collisions occur in a crash. And a crash does not necessarily mean a car crash. It means any sort of impact. The first collision is the vehicle of the crash hitting an object. The object may be moving or stationary. Second collision is the patient hitting the inside of a vehicle or crashing into another object or being struck by energy in an explosion. And the third collision are the internal organs hitting the walls of the body or being torn from their anchoring structures. So you have something like the aorta, which is prone to shearing, or you can have the bruising of other internal organs, or bruising of the brain when it's rattled around in the skull. So you have the first impact as a vehicle hits an object. So again, it doesn't have to be a car, but for this image, it is a car hitting a tree, and it's hitting a stationary object. Then you have the patient strikes an object. So you have patient coming forward, hitting parts of the car, the dashboard, the steering wheel, the knees can go under and hit the dashboard as well. Then you have the third impact, which is organs hitting internal walls. So you have the brain hitting the inside of the skull, or a number of other organs that can be sheared or torn away. The law of conservation of energy is energy can neither be created or destroyed, but it can be changed in form. So for example, the energy of a car in motion is changed when it crashes into an object, which causes it to decelerate. So say you have a car hitting another car, or a car hitting a tree, that energy is changed when it hits another object, and that energy can be transferred to another object. Newton's third law of motion: for every action or force, there is an equal and opposite reaction. It's probably the most commonly known law of Newton. It's a brief overview of kinetic energy. Formula for kinetic energy is 1/2 the mass times the velocity squared. Increasing velocity increases kinetic energy drastically. So you have velocity being squared in the formula for kinetic energy. Thus, high-speed crashes produce greater injury to patients. So even if you have two large cars that are hitting each other, if they're going at high speeds, it's going to be more likely that there's going to be greater injury to the occupants because the kinetic energy that's transferred to the human body will be so great. So key point: force involved in initiating an event, like a moving car or a bullet firing from a gun, is equal to the force transferred at the end of the event. So when a bullet is fired from the gun, that energy is somehow going to be transferred at the end of the event in the same amount. Stopping distance: the shorter the stopping distance, the more energy is transferred to the patient, which results in more injuries. So if you have a car hitting a brick wall, that patient is going to absorb more energy than if a car hits another car and keeps going and then stops. Compressible surfaces increase stopping distance and allow for more survivability. So if you have a compressible surface, something that isn't like concrete, it's going to be more likely that the patient will survive. Restrained drivers have less energy transferred to them because the restraint system absorbs much of the energy transfer. So part of the reason why unrestrained drivers are at such risk is not only because they can be ejected from the vehicle, but because instead of the restraint system absorbing some of the energy, the patient absorbs most of the impact. So a human versus a solid object impacts a certain number of body tissue particles. That's going to be where the injury is in place. So the number of tissue particles affected determines the amount of damage due to the displacement of energy. The density of the tissue and size of the contact area of impact determine the number of particles affected. There are 3 types of tissue densities. You have air density, which is the lung and some portions of the intestines. You have water density, which is muscle and solid organs. And then you have solid density, which is bone. You have cavitation. Cavitation occurs when a solid object strikes the human body and tissue particles are knocked out of a normal position, which creates a cavity. So if you have a bullet that impacts the human body, it's going to travel through the body. Those pressure waves are going to cause tissue particles to be displaced, and a cavity is going to be created. So there's 2 different types of cavitation. There's temporary cavitation, which is caused by the stretching of tissue during impact. And the elasticity of tissue will determine whether that cavity becomes permanent. So if you have a fairly elastic tissue that's hit, there's less of a chance that the cavity will become permanent. A permanent cavity or permanent cavitation is the cavity that remains after the temporary cavity collapses. And this cavity can be seen during patient exam along with the crushed cavity, so along with the penetrating injury. A permanent cavity would be something like the exit wound of a rifle. So you have typically with rifles, you have a small entry wound and then a very large exit wound. So looking at a patient, that exit wound, you can see that cavity going in that's larger than the actual bullet size. That's a permanent cavity. So there are 2 different types of trauma. You have blunt trauma. The force is spread out over a larger area and the skin is not penetrated. Then you have penetrating trauma. Force is applied over a small area where the tissue can penetrate the skin and underlying tissue. Blunt trauma. For the on-scene assessment of blunt trauma, you want to determine the direction of impact, as well as any external damage to a vehicle or structures. And then you want to look at the internal damage to the vehicle. So looking for steering wheel bending, windshield starring, any deformities of the car. It looks like a human impacted the car. You can look for starring on the windshield. Again, that's an indicator that the patient's head impacted the windshield. The impact for blunt force trauma includes two forces. You can have a shear injury. That's when one organ or structure changes speed faster than another. That causes separation or tearing. And you can also have a compression impact or compression injury, and that is when an organ or structure is directly squeezed between other organs or structures. We're going to look at a specific type of blunt force trauma, and this is a motor vehicle crash. So you have 5 different types of motor vehicle crashes that can occur. You can have a frontal impact, a rear impact, a lateral impact, a rotational impact, or a rollover. Let's talk about frontal impacts for motor vehicle collisions. So a frontal impact occurs when a vehicle suddenly stops and the patient continues to move forward one of these 2 ways. The first way is an up and over path. The second way is a down and under path. The amount of damage to the vehicle indicates the speed of the vehicle at impact time. In a frontal impact, the car transfers energy to the human body. The steering column can hit the chest. The sternum stops its forward motion, but the posterior thoracic walls continue to move forward. This can cause rib fractures, as well as crush injuries to the heart and lungs, because the sternum stops, but the posterior thoracic wall continues to move forward along with everything in the chest cavity. We'll talk about the up and over path. This occurs when the body comes up and over the steering wheel. The head will impact the roof or the windshield, and this is where you can see that starring pattern on the windshield. The cervical spine is the least protected, and the spinal column absorbs the impact as well. So if you have this type of impact, protecting the cervical spine is going to be a high priority. The chest or abdomen will then impact the steering wheel. This can cause a plethora of internal injuries. You can have shear injuries to the liver, kidney, or spleen. You can have compression of the solid organs. You can have overpressure injuries to the diaphragm, as well as cardiac, lung, and aortic injuries. The aorta and kidneys are specifically at high risk for shear injury. Then we have the down and under pathway. In the down and under pathway, the patient moves forward, down, and out of the seat, under, and into the dashboard. This is when you see the knees impacting the dashboard. So you can have 2 different impact injuries, really. You can have the tibia hit the dashboard, which can result in a dislocated knee, torn ligaments and tendons, as well as injury to the popliteal artery, which can result in lower limb ischemia. Or you can have the femur hit the dashboard. The energy is then absorbed and the bone may break. This is when you see a femur fracture. Can also have posterior dislocation of the acetabular joint. The upper body will continue to move forward as the lower half of the body moves down, and it can sustain injuries similar to that of the up and over, because then you're going to have the thoracic and abdominal areas hitting the steering wheel as well. Then we have a rear impact. So the bullet vehicle is the vehicle that strikes the slower moving target vehicle. So if you have someone stopped at a light, the bullet vehicle is the car that comes up behind them and hits them from the back. The greater difference between speeds means the greater energy at the force of impact. So this means a greater chance of injury. So if you have someone stopped at a light at a major intersection and someone comes up from behind and hits them at 60 miles an hour, that's a huge difference between speeds. That means greater energy, greater impact, and greater chance of injury. In this type of impact, the torso is forced forward, and hyperextension of the neck will occur if the headrest is not positioned. This is why it's important to have headrest, because in a rear impact, that headrest can absorb most of the energy, versus if there is no headrest, the neck snaps back and you have hyperextension. If the target vehicle does not strike another object moving forward, the chance of injury is lower because most of the body's movement is supported by the seat. So if the target vehicle is hit from behind and just rolls forward and is not hit by another car or doesn't hit some sort of wall or anything like that, the majority of the impact will be supported by the actual seat of the car. So the seat of the car will take most of the energy from the impact. Then we have a lateral impact. So lateral acceleration of the body and intrusion of the car frame into the body results in significant injury. Remember, a lateral impact is, you think of like a T-bone in a motor vehicle accident. You have a car moving forward and then it's hit from the side by another vehicle. So with a lateral impact, you can have clavicle compression and fracture if the shoulder is hit. You can also have compression of the thoracic wall, which will result in rib fractures, pulmonary contusions, compression of solid organs, overpressure injuries, and shear injuries of the aorta. Actually, 25% of shear injuries of the aorta are a direct result of lateral impact injuries. You want to keep that in mind. A lateral impact has the potential to compress and fracture the pelvis. The femur head is pushed into the acetabulum, which results in that pelvic fracture. For left-sided passengers, you have a possible spleen injury if they're hit from the left side. So that's the side that your spleen's on. And for right-sided passengers, you have that possible liver injury. You want to keep that in mind when you're assessing patients. And obviously, both sides could have either injury, but keep in mind that the mechanism makes it more probable that a left-sided passenger would have a spleen injury. You can have spinal cord injury as the body moves out from under the head. So you figure with a lateral impact, you have the body moves out and under the head, and then the head takes a little bit to snap back. So you can have dislocations, fractures of the vertebrae. You want to be looking at C-spine as well. And you can also have the head impact the frame of the door, which can cause a head injury. For a rotational impact, you have a combination of frontal and lateral impacts, resulting in frontal and lateral injuries. So with these rotational impacts, you can actually have injury patterns from both. The patient closest to the impact will have the worst injury because their body will absorb most of the initial energy from the impact. Other occupants will absorb less injury because it is diffused as the car spins and the frame of the car actually deforms. Keep in mind, though, a lot of rotational impacts often hit something else as they're rotating. So it's not just that initial impact. You know, one car hits and then the other car starts spinning and they can hit the side rail, or they can hit the concrete barrier, or they can hit several other cars on their way off of the road. So rotational impacts have the potential to be incredibly dangerous. Then you have a rollover. So rollover results in many impacts at different angles. Restrained patients typically have shearing injuries as their most common injuries. You figure the patient is restrained, so it prevents the patient from potentially hitting parts of the car or being thrown from the car, but the organs inside the body of the patient are not. So as that patient is rotating, the organs inside the body have the potential to shear or be torn from structures because of the force of the impact. In rollovers, unrestrained patients are typically ejected. This can result in them being crushed as the car rolls over them, or then they sustain injuries when they hit the ground. So you figure you not only have the force that ejects the individual out of the car, but then you have the patient hitting the ground at a certain speed. And we talked about how hitting a compressible surface increases chance of survival. Concrete is not a very compressible surface. And fairly well known, ejected occupants typically do not do fairly well. 77% of ejected occupants are actually killed. Then we have, in the same vein of motor vehicle accidents, we have motorcycle accident. And a lot of the kinematics is similar, except you don't have the frame of the car to absorb a lot of the energy. So all of the energy is absorbed by the driver. You have a head-on impact. In a head-on impact, the center of gravity is above and behind the front axle, which results in the motorcycle tipping forward and the patient is thrust into the handlebars or goes over the handlebars. So injuries include bilateral femur fractures if the mid-shaft of the femur impacts the handlebars. And you can also have open book pelvic fractures. And open book pelvic fractures are very severe and they have potential to cause massive hemorrhage into the pelvic cavity. So they are very serious. You typically want to treat that with a pelvic splint. You can also have an angular impact. This is a crush injury as the rider is trapped between an object and the bike. With this type of impact, you have upper and lower extremity damage as well as abdominal trauma. You figure an angular impact is just being hit at any other way than a frontal impact. Then you have the ejection impact. The full energy transfer will transpire at the point of impact to the body. So when a patient is ejected from a motorcycle, all of their body is going to absorb the energy from that initial impact, and then it's going to impact a surface like the road, another car, a telephone pole, etc. Another type of blunt force trauma is pedestrian impacts. There are, again, 3 phases of a pedestrian impact. You have the initial impact to the legs and the hips. You have the second impact, and this is where the torso rolls onto the hood of the car and may also hit the windshield. And for the third impact, the patient falls off the car and onto the ground, usually head first, of course, for some reason. The height of the vehicle and the pedestrian affect the injury pattern. So depending on how tall the individual is, you're going to see a slight deviation in injury pattern. So for adults, the first impact typically produces fractures to the tibia and the fibula because you figure the car impacts that kind of lower leg. The second impact is taken by the upper femur, the pelvic area. When that torso rolls onto the car, you can get rib and spine fractures, as well as crush and shear injuries. You also have injury to the head and the neck when you hit the hood of the car. In the third impact, you're going to have a significant blow to one side of the body, whatever side of the body that you land on, as well as a potential head injury when your head hits the ground. There are some pediatric considerations when dealing with pedestrian impacts. Since they're smaller, it's going to be slightly different. So the first impact is higher than in adults, and typically the femur and the pelvis are struck rather than the tibia and the fibula. And the second impact occurs almost immediately after the first impact. So you figure the size of a child, it's pretty much going to hit almost the entire surface of their body at the same time. And so that thorax is struck almost immediately after the first impact. And the third impact with children, since they're smaller, most of the time they don't go over the hood of the car, they go under it. So typically they're not thrown clear of the vehicle. They can be dragged underneath the car, go under the wheel, or just fall under the car. They're typically not thrown clear like an adult would. Falls are another aspect of blunt trauma. Some important factors. The height the patient fell from is incredibly important. So greater than 20 feet for adults and greater than 10 feet for pediatrics. You want to take into consideration the height of the actual patient. You also want to see what surface they landed on. How compressible is that surface? Did they fall onto a trampoline or did they fall onto concrete? You also want to look at the part of the body that was struck. Did they fall straight on their head or did they fall, onto their arm and then onto their head? Don Juan syndrome is the pattern of injury in feet first falls. So if someone tries to jump off a really tall building and they miscalculate how tall it was, that's when you get those feet first falls. You can have bilateral calcaneus fractures, compression shear fractures of the ankles, as well as tibia and fibula fractures. Typically, you'll also have long bone fractures, so that femur is going to break. You can also have hip fractures and tibial plateau fractures. So essentially, all that energy is going to be driven up and absorbed by your legs, and into your pelvic area. And you can also have compression fractures of the spinal cord as that energy travels up the body. Falls, so if you have pattern of fall where they fell forward onto their hands, you can have bilateral compression and flexion fractures of the wrists. And you want to make sure that you assess the part of the body that hit first, and then assess the pathway of energy transfer. For a fall onto a patient's head, the entire weight of the body compresses the head and the cervical spine. And this typically results in cervical spine fracture. So very obvious, you want to take C-spine precautions for that. Penetrating trauma. So the larger the frontal area of the projectile, the greater amount of energy is transferred. So the size of this frontal area depends on three things: the profile, the tumble, and the fragmentation of the projectile. So for the profile, it's the object's initial size. So if you're looking at a bullet, how big is the bullet, and does it deform when it impacts the body? So does it spread out and increase its surface area? For tumble, it's does an object turn at different angles in the body, which will create more energy transfer as it tumbles. And for fragmentation, whether or not the object breaks up into multiple parts. So if you have a bullet that when it hits the body, it fragments, that will result in more injury, more kinetic energy transferred into the body. Different weapons have different energy capacities. So there are 3 levels of energy. You have low energy weapons, medium energy weapons, and high energy weapons. Low energy weapons are hand-driven weapons. So you have knives, ice picks, anything like that that you can use to penetrate the human body that are hand-driven. So with these, less cavitation occurs. It's typically just the sole impact of the weapon into the body. So the blade may have been moved around in the body even if the entrance wound is small. So you want to consider that if someone's stabbed, for example, they might have shifted that knife around in the body, but all you're going to see is that small entrance wound. You want to determine what type of weapon was used, particularly the length and the width of the blade. Surgeons will want to know the length and the width of the blade. That'll help not only you estimate the damage, but the hospital and the OR. A fun fact, females generally stab downward, while men generally stab upward, as far as knife assaults go. Medium energy weapons. So these include handguns and rifles with muzzle velocities up to 1,000 feet per second. These type of weapons will cause permanent and temporary cavitation. You want to determine what type of weapon was used, as well as what type of bullet was used if you can. The distance from the shooter impacts the injury severity. So close range impact is going to transfer more energy as well as cause more injury. And this is the case for both high and medium velocity weapons. So the closer that person is to the shooter, the less kinetic energy is lost as the bullet travels through. So when the bullet impacts the body, it has more kinetic energy that it can transfer. Then we have high energy weapons. In high energy weapons, the muzzle velocity is greater than 2,000 feet per second. High energy weapons like an AK-47 can produce multiple cavities due to tumbling action. This is where you want to start thinking about that the bullet might have moved around in the body and you find an exit wound in the leg, but the entry wound is in the shoulder. The vacuum effect of these type of weapons pulls clothing, bacteria, and debris from the surface into the wound, so that can result in infection long term. You can also have fragmentation. So this isn't only if the bullet fragments, but you can have fragmentation on impact. It creates a large wound with soft tissue damage, and if bone is impacted, it can create large cavities and bone fragments become missiles themselves. So not only do you have the original missile, which is the bullet, you have all these other smaller shrapnel elements of bone, because with the high energy weapon, it's going to essentially blow apart a bone. For penetrating trauma, we want to identify entry and exit wounds. So for entrance wounds, typically they're round or oval. There may be abrasions or burns present if the bullet was fired at close range. Exit wounds are typically stellate or linear, and they're usually larger than the entry wound. Not always, but a lot of times they're vastly larger than the entrance wound. Organs hit will determine cavitation injuries as well. So not only does the velocity and the type of bullet used determine cavitation, the organ hit will determine cavitation. So muscle is more elastic and will return to a smaller permanent cavity. So it's like a flesh wound, essentially. It just goes straight through your muscle and doesn't really hit anything like an artery or organ or bone. Solid organs, however, are less elastic and will have a much larger permanent cavity. So something like the liver, if it is lacerated, it's going to have a fairly large cavity. There's not going to be really a temporary cavity. It's going to just be a permanent cavity. And we have the effects of penetrating trauma. So for the head, you have brain tissue is compressed inside the skull since it cannot expand. If the force is strong enough, the skull may explode from the inside out because all that pressure has nowhere to go and it will actually blow up the skull. A bullet may follow the skull curvature if there's an angular entrance and a medium velocity weapon is used. There's not going to be enough energy to actually create an exit wound, so all that energy is exchanged into the brain. That's actually one of the more lethal penetrating injuries to the skull, is to have that type of angular entrance with a medium velocity weapon. For the thorax, you have the pulmonary system and the vascular system that can be damaged. So for the pulmonary system, less damage is done to lung tissue because it's less dense, typically, but it can still cause significant damage. For the vascular system, smaller vessels can be pushed aside without damage, but larger vessels sustain heavy damage if they're hit. So things like the aorta or very large veins don't move aside like small vessels and capillaries will. Specifically for the heart, the myocardium is elastic and it will contract after impact, which may allow time for transport and help control the bleeding if it's a relatively small laceration. Obviously, if it goes straight through the heart, there's not much that we as emergency medical providers can do. For the GI tract, the esophagus can be ruptured depending on where the bullet hits or the penetration hits. For the abdomen, a low energy missile may not cause significant damage. So something like a knife might not always cause significant damage if it doesn't hit a vital organ or vessel in the abdomen. It could just stab into abdominal fat or muscle. Medium energy missile injury will likely need surgical repair, so gunshot wounds. Solid organs hit by medium energy missiles will not typically exsanguinate immediately. So versus a high energy missile, a lot of times solid organs can be blown apart or immediately bleed out. With a medium energy missile, you have more time because typically they don't bleed out right away. For extremities, you have damage to bones, muscles, nerves, and vessels. Obstruction of vessels can occur if the lining of blood vessels are hit. And hemorrhage can occur when muscle is hit and expands away from the missile. So for extremity injuries, you have those bones that can be damaged, that can be blown apart, can cause obstruction, and you can also, look for hemorrhages in the extremities. That concludes our course on the kinematics of trauma. So we reviewed kinetic energy and the different stages of the traumatic event. We also reviewed the workings of actual kinetic energy and how that applies to traumatic events. We looked at blunt trauma and the different types of motor vehicle crashes, motorcycle crashes, pedestrian injuries, and falls. And then we looked at the different types of penetrating trauma and the mechanisms behind that.
Question 1. Which of the following injuries is not probable in a lateral T-bone style crash? Option A, tibia fibula. Option B, abdomen. Option C, chest. Or option D, clavicle. The correct answer is option A, tibia/fibula. There are 5 areas of the body that are likely to be injured when a patient is involved in a lateral motor vehicle crash: the head, neck, clavicle, chest, and abdomen and pelvis. Question 2. You have responded to the scene of a motor vehicle collision. A small passenger car struck a power pole head-on. The patient has climbed out and is walking around slightly dazed. The patient is cooperative and appears to be atraumatic. The windshield has starring, and the airbags did not deploy. The patient gives you a complete medical history, but keeps asking what happened. What is your patient experiencing? Option A, anterograde amnesia. Option B, stroke. Option C, shock. Or option D, retrograde amnesia. The correct answer is anterograde amnesia. Anterograde amnesia occurs when a patient can remember all information before an event, but cannot remember anything that occurred after the event. Next question. You are on scene of a motor vehicle crash. Bystanders state that your patient was originally unconscious, but regained consciousness just prior to your arrival. Your patient is a 19-year-old male who is adamant that the accident wasn't his fault and he doesn't need to go to the hospital. He has vomited once, but says that it is from the stress of the accident. There is starring to the windshield of his vehicle on the driver's side. What do you suspect is wrong with your patient? Option A, epidural hematoma. Option B, drug overdose. Option C, intoxication. Or option D, subdural hematoma. The correct answer is epidural hematoma. The lucid interval is the key to the answer. Patients with an epidural hematoma often experience a lucid interval, a loss of consciousness that is followed by a period of time where the patient is awake and seems to be functioning normally. It is only a matter of time before the patient becomes unresponsive and does not regain consciousness. Next question. You are on scene of a motor vehicle crash. As you walk up to one of the vehicles involved, you notice starring on the windshield and the steering wheel is bent. What kind of injury path would you expect your patient to have followed? Option A, side to side. Option B, up and over. Option C, behind and front. Or option D, down and under. The correct answer is up and over. An up and over injury path is characterized by starring of the windshield from the patient's head striking the glass. The steering wheel may also be bent from the patient's torso slamming into the steering column. Next question. A secondary collision during a motor vehicle collision is best shown by which of the following examples? Option A, the impact of the driver to the steering wheel following the collision. Option B, a man hits a pole lying in the middle of the road with his motorcycle after it fell into the road when another vehicle struck it a minute prior. Option C, a package in the back seat of a person's car strikes them in the back of the head immediately following a collision with a power line pole. Or option D, a third vehicle is unable to stop coming around a corner and hits a car, which was just involved in an MVC with another vehicle. The correct answer is the impact of the driver to the steering wheel following the collision. Secondary collisions are generally collisions that occur because of the initial collision. A package strike could be a secondary collision, but the best answer is the patient hitting the steering wheel. Next question. Which 3 of the following are types of vehicular impact? Option A, end over end. Option B, rotational. Option C, frontal. Or option D, rollover. The 3 correct answers are rotational, frontal, and rollover. End over end is not a term used to describe motor vehicle collisions. It would instead be termed a rollover accident. Next question. On arrival at an MVC, you find a patient seated in a vehicle that has severe damage to the front end. You notice the patient has a laceration to the forehead, and the windshield is cracked from where the patient hit his head. You would immobilize the patient how? Option A, short spine board while the patient is still seated. Option B, rapid extrication with a C-collar and longboard. Option D, log roll while the patient is still seated. Or option D, rapid extrication on a longboard. The correct answer is short spine board while the patient is still seated. Due to the mechanism of injury, you should suspect this patient to have a spinal injury and should immobilize the patient with a short board, or KED, prior to removal from a seated position. Rapid extrication should only be used in cases of a critical trauma patient. Next question. You respond to a 52-year-old female with pelvic instability after a ground level fall. She is in a significant amount of pain in her left hip/pelvic region, and vital signs are currently stable. Of the following courses of treatment, which should you consider most? Option A, rapid transport, C-spine precautions, trauma system entry. Option B, IV pain medication, pelvic splint, C-spine precautions. Option C, IV pain medication, Sager splint, C-spine precautions, trauma system entry. Or option D, C-spine precautions, trauma system entry, Sager splint application. The correct answer is IV pain medication, pelvic splint, and C-spine precautions. The pelvis can hold over 1,500 milliliters of blood and can easily put a patient into shock. Along with pain medication, if not contraindicated, you should apply a pelvic splint and consider C-spine precautions. Under most circumstances, this type of injury would not warrant a trauma system activation. A Sager splint is used for femur fractures and is contraindicated with suspected pelvic fractures. Next question. You are performing a physical exam of a 32-year-old male patient after a fall. He fell backwards on his head, and there are some deformities to the occipital bone. He has positive signs of cerebral spinal fluid extruding from his ears. If there were damage to the occipital lobe of the brain, which of his senses would expect to have some disturbances? Option A, vision. Option B, hearing. Option C, taste. Or option D, smell. The correct answer is vision. With a head trauma, the injury pattern can be unpredictable and there can be multiple systems severely affected. The occipital lobe of the brain controls vision, and damage to this area can present with problems with reading and writing, identifying movement, and possibly hallucination. Next question. You are called to a private residence where an 80-year-old female has fallen down a flight of stairs. She reports intense pain in her right hip. After checking CMS, you discover that the patient does have a pedal pulse, but does not have full motor or sensation on the right side. It is important that this patient be transported using options are, option A, scoop or orthopedic stretcher, option B, long spine board, option C, basket stretcher, or option D, portable stretcher. The correct answer is long spine board. The patient has suffered a traumatic injury from a significant mechanism of injury. Therefore, full spinal precautions must be taken. The scoop stretcher would only be appropriate if spinal injury was conclusively ruled out. In this situation, it is not.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.